I'll join in 2 minutes. 2 minutes.
Okay, sir. We will wait, sir.
No problem, sir.
Yes, sir.
Yeah, it depends on your convenience. For me, no issues.
Motwani, sir.
Yeah, please. Yes, please.
Good evening, everyone. Respected seniors, colleagues, and dear PGs. I welcome you all on the behalf of Durg Bhilai Academy of Pediatrics in today, Tuesday, PG Clinic session. Today, the case will be presented by Dr. Praveen Kumar S., his third year PG from Pandit Jawaharlal Nehru Medical College, Raipur. And as you all know, today our faculty is Dr. S. Balasar. He is a senior consultant, HOD, Director from Kanchi Kamakoti Child Trust Hospital, Chennai. I welcome you, sir. And our second faculty, Dr. Naresh Motwani, sir. He is a professor in the Department of Pediatrics in Sri Sankaracharya Institute of Medical Science. I welcome you, sir. With this, I'd like to invite Dr. Praveen Kumar S. for his case presentation. Praveen Kumar, please.
Good evening, everyone. Myself, Dr. Praveen Kumar S. I'm a third year resident PG in Department of Pediatrics, Medical College, Raipur. Vicky Dali, 4 years, 6 months old male child, second born to non-consanguineous married couple, son of Biplab Dali, Hindu by religion, resident of and currently residing in Kanpur, Chhattisgarh. Date of admission was 19/6/2024 and date of examination was 19/6/2024. Patient was presented with chief complaints of fever for 5 days and rashes all over the body for 5 days. And slide this one is good. And non-stoppage of bleeding from the injured side following trauma for countries 2 days. History of presenting illness as per history given by his father, who is a reliable source of information. Patient was apparently well and was gaining weight and height normally. Started developing fever, rash, and non-stoppage of.
The slide is not moving.
Yes, sir.
Yes,
sir, moving, sir. It's moving, sir.
Okay.
As per history given by his father, who is a reliable source of information, patient was apparently well and was gaining weight and height normally. Started developing fever, rash, and non-stoppage of bleeding following injury for 5 days. Complaints of fever for 5 days, which was sudden in onset and high-grade in nature, recorded in a private clinic, 104 degree Fahrenheit. Fever was initially high-grade and continuous for first 2 days, and then resolved gradually with medication prescribed by a private doctor. Details not available. From 4 spikes per day to 1 spike per day. During interfebrile period, the child was active. Fever was associated with onset of purpuric rashes all over the body for 3 days, which was sudden in onset and progressive in nature. Rashes appeared on the first day of fever. It appeared first over the abdomen region and gradually progressed to chest, forearm, thigh, legs, and face within 2 hours of onset of rash. Arms and shoulders were not involved. Genitals were not involved.
No, 1 minute.
Rashes
Dr.
was
Pradeep,
not associated with itching or pain.
Dr. Pradeep, please
Yes,
speak a little slowly. Right? Don't be in a hurry.
Yes,
We are not in a great hurry.
Yes.
Okay, please slow down
Yes,
your presentation. Okay, be measured. See what happens even in the exams. There are 2 things which can happen if you present too fast. You know, the examiner will not be able to. He will think you have not mentioned so many other points, though you would have mentioned in your speech. So please present slowly.
Yes,
okay, please go ahead.
Yes, sir. Yes, sir. Palms and soles were not involved. Genitals were not involved. A rash was not associated with itching or pain. A rash was not aggravated with sunlight. Her mother was applying some ointment given by a private doctor. Details not available. After application of ointment, rashes reduced to some extent without local scarring of skin. Fever was associated with mild cough and cold from second day. Fever, it was dry cough, intermittent in nature, no diurnal variation, no specific aggravation or eleving factor. Fever was not associated with breathing difficulty, ear pain, ear discharge, headache, vomiting, throat pain, abdominal pain, burning sensation or pain during micturition, diarrhea, joint pain, fatigue, altered sensorium, abnormal movements. Fever was not associated with chills, rigor, or increase in paleness of palms and soles. Patient had cell fall 2 days back on 3rd day of fever and sustained injury over the left side of forehead Following head injury, patient is bleeding for 2 continuous days, scanty amount, visited to a private doctor and dressing was done. And advised some local ointment, details not available. After application of ointment, bleeding stopped with formation of clot and local swelling. No history of loss of consciousness, vomiting, headache, ENT bleed, abnormal movements. No history of abdominal distension. No history of redness of eyes. No history of blood transfusion. No history of passage of blood in urine or stools. No history of yellowish discoloration of skin or eyes. No history of passage of black colored stools. No history of joint pain, swelling of limbs or joint. No history of loss of appetite or weight loss. Past history. No history of similar events in the past.
One minute.
No history
Just a
of blood
minute.
transfusions.
Kishore, please don't go to the past history. Just leave it. Just leave it. In fact, today what I am going to do is to be an observer. It's a very happy day for me.
Mhm.
For the simple reason to see Dr. Naresh Motwani, who's joining me as a faculty for a discussion, right? So I'm going to ask him to take the lead. First, I mean, you can stop with this present history and let Dr. Naresh take up the issue so far. Then I'll come in if necessary. Okay, it's a very, very proud day for me to see my own student rising to the level of HOD of medical college and doing so well. Okay, he was one of our best students. I'm so happy. Over to Naresh to begin with.
Sir, right now I'm ex-HOD.
Oh, okay, fine. Sooner or later you'll be HOD. No problem.
Sir, you are my teacher. You will be the boss. So
Yeah.
okay, I'll begin, sir, as you have said, I'll begin. So what is this likely? You are saying fever since 5 days, which are sudden in onset and high grade. So can you just
Yes,
based
sir.
on the fever symptomatology, can you tell me what are you thinking in your mind? 5 days fever, which is
Sir,
high grade and sudden in onset.
yes, sir. Yes, sir. So it should be viral etiology, sir, because fever was suddenly onset and high grade initially, sir. And interfebrile period, patient was active actually, sir. So bacterial fever, patient will be dull, sir. Actually, it is
No.
interfebrile period, patient is active, so it's a viral etiology, sir.
Okay, so what are the other symptoms, no, when you're thinking of viral fever? So what are the other symptoms you asked to say it is most likely viral? Apart from interfebrile period, the child is active, but any other clinical features which goes in favor of viral fever, and you said so.
Yes, sir. Rhinitis is there, sir. Right? Cough and cold is there. Running nose is there. Running nose is for 3 days, sir.
Mhm. Okay, so running nose is there. That's it.
Yes, sir.
Anything else?
Viral etiology. Then fever with rash is there, sir. Dengue is possible, sir. It can be viral fever also, sir.
So you mean to say it is localized infection? It is respiratory tract infection. That's why the child is having fever.
No, sir, not localized infection, sir. It is basically it is fever with rash, sir. Vasculitis, sir. It's not a local infection, sir. Or multi-system involvement, sir.
I am talking about fever. So when you say the child is having fever since 4 to 5 days, child is active. What are the other points which goes in favor of viral fever?
Initially
Viral
grade is
fever,
high, sir. 104.
are the symptoms of viral
Uh,
fever diffuse or they are generalized?
Sir, generalized, sir. Actually, generalized, sir.
Generalized. What other generalized symptoms may be there in a child who is having fever, viral fever?
Sir, high grade fever, sir. Then rhinitis will be there, sir. Fatigue will be there, sir. Joint pain will be there, sir. Generally, normally body pain, full body pain, and fatigue will be there, sir.
So see, the viral fever usually they have multi-system involvement. Usually, the child may be having
Yes, sir.
rash also, skin involvement may be there, eyes may be suffused, conjunctival congestion, respiratory symptoms may be there, cold, cough, or the child may also have diarrhea, okay, loose stools and all.
Yes, sir.
Okay, but the interfebrile period, as you mentioned, the child will be active and all. So what went wrong then? You
Yes, sir.
suppose we are thinking of viral fever. Then the second symptom, what was the second symptom?
Sir, fever rash, sir. Rash, purpuric rash, sir. Purpuric rash.
Okay. So the child is having rash, purpuric rash. Can you tell what exactly you mean purpuric? The patient, what did they tell you? What was the type of rash? How did you
Sir,
ask?
they told like that after onset of fever on the first day, mother noticed like bluish discoloration of skin actually, sir, over the abdomen region, and it gradually progressed towards the arms, forearms, legs and thighs and legs, and followed by face, sir. So by bluish coloration of skin, I thought it's purpuric rash, sir. So to describe a rash like macule, papule, or if I should describe something, sir, I thought it is a purpuric rash. So I used the word purpura, sir, because it's terminology is not complete without describing the rash, sir. So it's macule, papule, or purpura ecchymosis, or I think it's his mother is saying that it's blue discoloration of not cyanosis, sir, bluish discoloration of skin over the abdomen, like he's saying. So I think it's purpura rash, sir.
Why not petechial rash? Why purpuric rash?
Sir, petike, purpura, sir, petike size is less than 3 millimeters, sir. It's not visible in naked eye, actually, sir. They are also not aware.
That means,
Then
on
coming to
history,
purpura, it is 3 to 10 millimeters purpura, more than.
so that is on examination, right? So based on history, can you come to a conclusion what type of rash? Is it
Yes, sir.
petechial rash or is it purpuric rash?
The purpura, petike is, patient is not complaining of specific spots,
So
complaining of
based on
rash,
the
actually. Whole body
so
diffuse
based on
rash,
the size of rash,
they're selling.
if it is pinhead size rash, macules, reddish dots, you can say it is
Yes, sir.
macular,
Yes, sir.
petechial, right?
Yes,
But
sir.
if they are larger, no, you can
Yes, sir.
say
Yes, sir.
probably purpuric rash. So you could have asked straight away what is the. So initially, sometimes they may have petechial rash, which may later form purpura, right? So to begin with, what was the
Yes, sir.
onset of rash? Whether it's petechiae, whether it's purpura, that is also you can based on your history, you can also ask. Okay. So based on the size of what is the size of the rash?
Yes, sir.
So what do you think now? Now
Yes, sir.
initially you're having a child who's having fever, and in between the child was active, child is playful. According to you, no other symptoms, and we are assuming that it is viral fever, right? But now after 2 days, the child
Yes,
is
sir.
also having this kind of rash. Okay. Now what are you
Yes,
thinking
sir.
in your mind? What it is likely?
Sir, fever with rash, sir. Maybe it can be dengue complications, sir. Maybe like dengue causes vasculitis. So it can be like petike. It can be fever with rash complaints. It can be viral exanthem, sir. Viral exanthem, it will come under, sir.
Viral exanthem. Which viral exanthem will present
Yes,
like
sir.
this?
Sir, it can be dengue, sir. Or second is, it can be
Dengue, what
dengue,
type
sir.
of
Dengue
rash you
virus.
get?
They are all hemorrhagic disease.
To begin with, what
Sir,
type of rash?
dengue, we will
Dengue.
get a petike.
See, petechiae, when do you get petechial rash? Do you get the petechial rash in dengue initially?
No, sir. 4 to 5 days back, sir. 4 to 5 days after the illness of fever, you will get the,
So
at the time of critical period, you will get the rashes, sir.
initially, when will you suspect dengue? What type of rash the child will
Sir, at flexural areas, sir, there will be petike will be there, sir, easily. If you notice the appointments, first point of occurrence
have? No,
of
no.
petike is the flexural point, sir.
See, this petechial rash develops once there is onset of thrombocytopenia, and usually by the time the fever subsides, right? But here the child is febrile.
Yes, sir.
But child is already
Yes,
febrile
sir.
and is not gone into afebrile phase or
Yes, sir.
critical phase, and onset of rash is on second day and third day here. But in dengue, which kind of rash you usually get?
Yes, sir.
Erythematous rash. Okay, the erythematous, palms and
Yes, sir.
soles will be red, conjunctival suffusion may be there, whole skin may be erythematous. So it's called erythematous rash in early in dengue. Okay, you don't get petechial rash initially in dengue usually.
Yes, sir.
Okay, it is very rare. Usually
Yes, sir.
they will have this rash, then the child
Yes,
may
sir.
become febrile or the child may have fever low grade, but then the child will develop that kind of rash. What was this rash spontaneous or was this associated with any trauma?
Spontaneous,
That
sir. Was spontaneous.
whatever rash is. Okay, is it important to ask?
Yes, sir. It can be, suppose if it is urticarial rash also spreads fast, actually. So urticaria like rash also gets faster. On further traumatized, it will is all will spread further, actually, sir. So it should ask whether trauma is there or not, sir.
You said this rash is not with itching, right? Is there any itching?
No, sir. No itching, no pain, sir.
Can you tell me some conditions where the child is having fever, child is having rash, and there is associated itching?
Uh, Fever, rash, itching. Sir, Dress syndrome, sir. Drug related eosinophil and symptoms, sir. Or the patient will, and also in urticarial person like this, sir. Urticarial person like this.
Urticarial rash.
And also in mild case of ITP, sir, idiopathic thrombocytopenic purpura, they will present like this. Itching will be there, then will be there this then appearance of rash, fever, subsiding of fever, then itching and rash. ITP also will be possibility, sir.
ITP. Okay. So how do ITP present
Yes, sir.
basically? Does it present during
Sir,
fever?
ITP present
rash?
this. No, sir. After not fever, sir. At least 5, 10, 7 days back, there should be fever. Then after resolution of fever, there will be onset of purpuric rash, sir.
Yeah. Okay. So during fever, if a child is having rash, will you think of ITP?
No, sir. No.
Okay.
It
So
can be
if the
two things,
child,
sir. Suppose rash it can be acute.
okay, now this
Yes, sir.
child is having fever and child is also having rash, right? So the purpuric
Yes,
rash
sir.
as per you. So what are the likely causes you'll think of? What else you would like to know in the history?
Sir, it can be acute leukemias also, sir. So previous
Leukemia.
history of prolonged history of fever, acute leukemia, sir.
You talked about fever, which is only for 4 to 5 days, and the child is having
Yes, sir.
rash.
Yes, sir.
So will you consider leukemia first in this trial? We are just
Sir,
only in the
fever,
history.
rash,
We are
continuous.
not exam. Yeah.
No, it's likely unlikely, sir.
What
It
are the other
mostly,
conditions where this child may present, like fever, child is also having a rash, and you have mentioned purpuric rash. So can you, because it is very, very critical to identify them early. Because after 1 or 2 days, if you
yes,
don't identify, you may lose a child. What are those situations? Have you heard of meningococcal infection?
yes, sir. Meningococcemia, sir. Fever, rash, meningitis, then purpose spot all over the lower limb, sir. Yes, sir. Meningococcemia, Neisseria meningitis. Yes, sir. Yes, sir.
Septicemia, even
Yes, sir.
in this season, malaria. Okay. So most
Yes, sir.
common things first you should think of, na? A child who's having fever for
Yes, sir.
5 days, child is having a rash, and you're thinking it's purpuric rash based on your history or petechia purpura, then you will think of common things first, right? So rickettsial
Yes,
infections
sir.
are there, malaria is there, your dengue is there, okay? Even enteric,
Yes, sir. Yes,
5
sir.
days fever. It doesn't mean that if the child is presenting in first 5 days, you will not think of enteric. Of course, the other
Yes,
symptoms
sir.
may be there, but infectious disease, whatever common in our setup, we should think of those things first. Okay. Now there is also
Yes,
history
sir.
of bleeding. You said bleeding from the head. What is that?
Yeah. Sir, actually, third day of fever, patient complains of self-follow 2 days back, sir. Following
Hmm.
injury, patient is having left side frontal region continuous bleeding, sir, for 2 continuous days, scanty amount.
And you said the child is in continuous bleeding from that injury site, right? So
Yes, sir.
I just want to
Yes,
ask
sir.
one thing: was it a trivial trauma?
Not trivial trauma, sir. Like
Injury?
mild trauma, sir. No, sir. Not trivial injury, sir. Mild injury, self fall from bed, actually, sir. Not mild injury, sir.
So why a child who is having mild injury should bleed continuously for 2 days? What you are thinking in this situation?
Sir, suppose if it is a viral exanthem, dengue-like illness, they will thrombocytopenia will be there, sir. Local practitioner can prescribe NSAIDs like mefenamic acid or some other drugs. It can precipitate bleeding like this condition, sir.
For 2 days, but does that precipitate with trivial bleeding, trivial trauma? That too in
Yes, sir.
second
No,
day
sir.
or third day of fever. Third day of fever.
Yes, sir.
What could be the cause of this continuous bleeding according to you? Is it a superficial bleed or deep bleed? I am giving you clue.
Actually, sir, this patient is having deep bleed actually, sir. I think whatever the local practitioner applied, I think it's bottle place. So only the blood gets clotted and form hematoma local site there. I think it's maybe deep laceration will be there. It forms a local clot, then it forms hematoma there, sir.
No, what do you mean by deep bleed? When I ask whether it is superficial bleed or deep bleed, what do you mean by deep bleed? See, whenever you are
Deep
having a
bleed,
child, whenever you are having a child who is bleeding, so when I say deep bleeding, I would like to ask whether it is a bleeding into the muscles like deep tissues, like within the organs, or is it in the joints like that, or is it superficial? Superficial means whether it is in the skin or only the mucosa is involved, like epistaxis, gum bleeding like
then
that.
yes, sir. Then
Okay,
superficial, not deep, sir. Not deep. Not deep bleeding.
okay. So any clues, any guesses why this child is bleeding continuously since 2 days? Third day से fever है उसको, ठीक है? On day 3 of
Yes,
fever,
sir.
the child had a fall, but the child is bleeding continuously and it is superficial, as you said. So what could be the cause for this?
Yes, sir.
Is it the injury itself or something else is adding to it?
Sir, blood parameters should be abnormal, sir. Maybe coagulation defect will be there, or a platelet pathway defect will be there, sir.
Okay, so you are thinking of coagulation defect or some platelet defect? What is it?
Hemorrhagical disease, sir. Platelet disease, coagulation is also can be kept, sir. Maybe it's a disease, hemorrhagical system is involved, actually, sir.
So why on day 3 a child who is well looking child is playful, child is interfebrile period, well child, why this child will have coagulation defect?
Sir, maybe chronic conditions maybe will be there, sir, like chronic ITP or already coagulation
Chronic,
defect pathway will be there.
chronic
Maybe,
ITP will get coagulation defect.
no, sir,
Suppose
not
this
chronic
child is
ITP, sir. Leukemia, sir.
See, suppose this child is sick child, I could have understood that this child is having probably some infection or sepsis, something like that, that the child is having some coagulation abnormality. But a child who is well child, you
Yeah.
said, the child is well in between interfebrile period, and you're suspecting some viral infection, right? Then why this child will have coagulation abnormality? So when the bleeding is
Sir, why?
trivial due to trivial trauma and superficial bleed, so most likely it has to be either, what are the causes of superficial bleed?
Superficial bleed, local injury, sir. Local trauma is the main cause in pediatrics.
But it should stop now. Where is the hemostasis here? It is child is bleeding continuously.
Yes, sir. Actually, sir.
Bleeding. What do you do
Yes, sir.
once the child is having superficial bleed? What will you do immediately?
Apply pressure, sir. Apply local pressure.
So they must have applied, right?
Yes, sir. But blood was not stopped, actually, sir.
So why this child is now having problem? What is the likely problems? So what are the situations where this scenario comes? The child is bleeding continuously. That is superficial bleed. What are the situations? Pathophysiology.
Sir, sir.
So Bala sir,
The
sorry sir.
patient may be having some.
No. I am enjoying it thoroughly. You are doing it very well. Go ahead.
The patient will have some chronic pathology in the beginning, sir. Maybe like leukemias or platelet pathology will be there. Today, the fever is aggravated the condition, actually, sir. Patient will be patient will have illness from before also, but they are not noticed, actually. Why illness aggravated this cause, actually, sir. This can be possibility, sir.
But you have mentioned the child was apparently well till 5 days ago. Only
Yes, sir.
then the child
Yes,
had,
sir.
right?
Yes, sir. Yes, sir. Yes, sir.
Okay. So had the child having some chronic disease, some symptoms must have been there at least, right?
Yes, sir.
What are those symptoms if you are thinking of some chronic pathology? What are the symptoms? You said there is no history of loss of appetite or weight loss. Okay. What other symptoms? You said
Sir,
no history of
suppose.
joint. You said there is no history of joint pain or swelling of limbs or joints.
Yes, sir.
Suppose if it is child is having chronic pathology, child is having fever, child is having this purpuric spots or petechiae, and the child is having joint pain. What will you think of? Is it joint pain or something else?
JA is a juvenile. Sir, actually, it can be arthritis, sir. It can be arthritis. Chronic patients, suppose patients have joint pain, fever can be arthritis, sir. JA is a for recreational can be JA also. So reactive arthritis also possibility. Reactive arthritis also possibility, sir.
Okay, GI, you're thinking of GI.
Dr. Praveen Kumar, you have done
Yes,
so
sir.
far very well. Must appreciate you. You just go back to the first slide in the history. First slide in the history. Please go back. Go back. Please go back. No, first slide, presenting symptoms.
Complaints first.
Please go to the previous slide, previous one. First slide in your
One slide back.
presentation. Where you,
Sir, I already done,
yeah.
sir.
Yeah.
That's all. Just wait. Actually, there are. I like the way you started. For the simple reason you said this child was previously well. But I'm extremely happy that you mentioned child was gaining weight, height, everything was perfect. And this is not a child who has been chronically ill and who has developed an illness. That's first my compliments to you for beginning, because you have clearly mentioned that the whole thing has started only 5 days back. And in the history, you have given 3 very important symptoms. The first symptom is fever. The second symptom is a rash. The third symptom is uncontrolled bleeding after probably a trivial trauma. I would say, I'll tell you why I'm making such a guarded statement. Okay. First, you said fever, and the fever is persisting. Yes or no?
Yes, sir. Fever persisting, sir. But
Persisting.
after paracetamol, fever is kind of
No.
studies.
If fever is persisting, it is not resolved.
Yes,
Am
sir.
I right?
Not resolved, sir. Persisting. Yes, sir. Correct, sir.
That is one. That is a fever is persisting. And which day of fever? Can you go to the next slide? Which day of fever did the rash start?
First fever, sir.
First day itself. Day 1.
Yes, sir.
Day 1. Now, you had mentioned that the rashes were purpuric.
Yes, sir.
But I never heard you mentioning whether there were ecchymosis also or not. Were there ecchymosis or there are only purpura?
Ecchymosis also was there, sir.
Purpura and also ecchymosis was there. Okay. Now you
Yes,
use the term that this child has got vasculitic rash. That's what you mentioned. Okay. Why did you say that this is vasculitic rash? And when will you, from the history, come to a conclusion a rash is due to vasculitis? What is the difference
Sir,
between...
pain.
Wait. What is the difference between a child who has a vasculitis and a rash and a child who has a rash due to a bleeding diathesis or thrombocytopenia? From the history, how will you differentiate?
Sir, they will be painful, sir. Vascular will be painful.
Not necessary. See, what is the commonest vasculitis which causes a rash? What is the commonest?
Dengue, sir. Dengue fever, sir.
Vasculitis.
Kawasaki.
Oh, Kawasaki. Somebody has put in the chat box, Dr. Kruti, HS purpura. What is the most common distinguishing feature of HS purpura from the purpura due to dengue or viral infection? What is the essential clinical feature which the mother herself will tell you? Palpable purpura. That is what I wanted from you. So you could have
Yes,
mentioned
sir.
whether the rashes were palpable or not. If the rashes had not been palpable, they are unlikely to be vasculitis induced rash.
Vasculitis.
Number one. Number one. Okay.
Yes,
Second,
sir.
so this is not likely to be vasculitis from what you said, because you are not, rashes are not palpable. Am I right? Am I
Yes, sir.
right?
Not hospital, sir. Not hospital. Yes, sir.
And you all, was there a bluish discoloration when the rashes were there for more than 24, 48 hours? That also will give you a clue that it is ecchymosis and it is a bleed and not a vasculitic rash. So bluish discoloration, non-palpable rashes will give a clue it is not vasculitis. That is point number one. The second, you thought of dengue. I wouldn't think of dengue at all in this child. Dengue is not a diagnosis I am going to think in this child. Can you tell me why? Why I am saying from your history? What are the points against
Because
dengue?
continuous fever is there, sir. Yes, sir. Continuous
That may
fever
be
is
there
there.
only 5 days now. Dengue may have fever for up to 7 days. It is
Yes, sir.
a simple rule of thumb is that any fever beyond 7 days, dengue is unlikely, primarily. So it's only 5 days, it can still be dengue. What is against dengue in this child? What is against dengue in this child?
Ecchymosis, sir. Ecchymosis.
Ecchymosis can occur in dengue. If there is severe
Yes.
thrombocytopenia, you can have ecchymosis.
Which
Few
day
points
usually,
are
sir?
against
Bleeding, sir, actually.
dengue in this child. I'll tell you why.
Yes, sir.
See, you said that the bleeding, the rashes started on day 2 of illness. That is very, very unusual in dengue. You don't get petechiae purpura in second day of fever in dengue. That is one. Second,
Yes, sir.
you don't get bleeding after trauma in dengue. You don't get that. See, a child bleeding for 48 hours after a trivial injury, that's not dengue. Not dengue. And third, in spite of the child bleeding, in spite of the child having so much of rashes, fever is still persisting. Usually bleeding, child becoming sick, fever will disappear. So these are all the important points which tell me that this is not dengue. Not dengue. Okay. The last is, you said that there was some trauma, but you didn't tell me what trauma was it. To me, it is very, very important. If there is a serious fall, major fall like a road traffic accident, you can bleed like this from an artery injury, even without a coagulation disorder. But the most important point that you must remember, if a child starts bleeding after a trauma, what clue do you get? Where is the defect? Basically you must remember, any bleeding diathesis can be etiologically due to a defect in coagulation system or a defect in platelets or a defect in the vessel wall or collagen or a combination of more than one. So any child who has a bleeding diathesis to me has to fall into one of these three groups. Now tell me, in this child who has had petechiae ecchymosis and who starts bleeding after a trivial trauma for more than 48 hours, where is the defect in this child? Is this child having a defect in the platelets, either in terms of number or function, or a defect in the coagulation factors, or a defect in the vessel wall, or a combination of more than one? That's what I want from you.
The platelets, sir. Platelet dysfunction. Sir.
Platelets. No. I can tell you, platelet disorder. See, basically, I'll just tell you. I'll ask you one simple question. This is one of my favorite questions to postgraduates. You have a child with hemophilia. Okay, will you do bone marrow to a child without giving? Suppose you
No,
want
sir.
to do a bone marrow. Will you do bone marrow? Will you do bone marrow aspiration to somebody with hemophilia whose factor VIII level is very low? Will you do?
No, sir.
No.
No, sir. I will not do.
But you have a child with a diagnosis of ITP, platelet count is 10,000, 20,000. Will you do bone marrow or will you give platelet transfusion then do bone marrow?
No, sir. I will do bone marrow, sir. I will do bone marrow.
Why? What is the difference between the two?
Because ITP patient will not bleed. 30% will develop bleeding, sir.
Why you will do in ITP? Why you will not do in hemophilia? I want you to tell me the fundamental reason. See, it is
Hemophilia is
because
a clotting pathway defects.
tissue thromboblastin will be there to stop any bleeding if you do a bone marrow. Nothing will happen. That is because the coagulation cascade is intact in ITP. It is not intact in hemophilia. If you can't do a bone marrow to hemophilia, we can jolly well do, even if it is 5,000, you can do bone marrow to somebody with ITP. Unless PTT is abnormal. So the point that I am trying to tell you is, you have to, from the history, identify which group of bleeding diathesis. If you ask me, this child has a problem in more than one place, because you have said there is petechia and purpura, which is not palpable. I think this child has got a thrombocytopenic purpura 1. Because this child has started bleeding after trauma, trivial trauma, there is also a coagulation factor defect in this child. So it is a combination of both coagulation factor defect and a platelet factor defect, which is there in this child, which doesn't occur in dengue. Of course, dengue rarely can get abnormal coagulation, PTT prolongation. That's not usual. That occurs in the setting of some dengue shock syndrome with hepatic encephalopathy, hepatocellular failure, or your dengue-induced HLH. Otherwise, you don't get that. So, dengue is not at all a diagnosis in this child. So, with 5 days of fever, with bleeding due to a problem in the platelets and a problem in the coagulation factor, what is the probable diagnosis you are going to think of at this point of time? Now, please tell me. This is not dengue. This is likely to be a lymphoreticular malignancy, or rarely some disseminated viral infection resulting in coagulopathy, disordered the platelet function, disordered platelet numbers, etc. Okay, that is my conclusion. This history. Yes. I hope Naresh would agree with me.
Yes, sir.
Yeah, that is it. The next point I wanted to tell you, please go to the next slide. Please go to the next slide. Next slide. Please move your slides. Yeah. Go on. So my conclusion is that this child continues to have a febrile illness without localization, except for a trivial running nose. And this child has thrombocytopenic purpura and petechia and ecchymosis. This child has unusually severe bleeding following a trivial trauma, suggesting a coagulation factor defect. This child is likely to have an acute febrile illness resulting in disordered coagulation and thrombocytopenia. Either it should be an unusual infection, unlike dengue, or it is a lymphoreticular malignancy. That is my conclusion in this child. Okay, please go ahead.
Yes.
And in fact, one of the things very often we ask you must know how you should distinguish a disorder of platelets and a disorder of coagulation factor. There are many points. I'll tell you how to differentiate. Spontaneous bleeding is a feature of platelet disorder. Okay. Cutaneous bleeding, mucous membrane bleeding is a feature of platelet disorder. 4. A platelet disorder child is unlikely to present with hemarthrosis. Okay. Family history may not be there by and large in most children with platelet disorders. On the other hand, a coagulation disorder, family history may be there, bleeding after trauma may be there, joint bleeding may be there. In general, male sex is more likely to have a coagulation disorder. These are all some of the differences, okay, between a platelet disorder and a coagulation disorder by and large. Okay, right, go ahead.
One more thing, sir. You
Past
said,
history.
Praveen, you said ki in between the interfebrile period, the child is normal or active. That also I'm little doubtful, because once you are giving paracetamol and such a history, background history and all, I don't think this child would have been normal in between. I have my own doubts. Though you mentioned that the
In fact, one of the things, Naresh, students, you'll be surprised to know there are beautiful papers which suggest in an acutely ill child with fever, therapeutic response to paracetamol is not a reliable indicator that it is viral infection, whether it is meningitis or osteomyelitis or pneumonia or viral fever, paracetamol might work. So just because paracetamol does not bring down the fever, it doesn't mean it is bacterial. Just because paracetamol brings down the fever, it doesn't mean it is viral. You cannot distinguish. I'm quoting literature. So that's not reliable. Of course, in general, in the interfebrile period, children with viral infections are likely to be normal in behavior, are likely to be. But for every rule, there is an exception. It's not very highly reliable. Right? I don't think I will think of viral infection in this child for the simple reason this disease. It started with a fever, and day 2 itself it started with rash, and day 4, day 5 coagulation problem. This is something which is progressive, which is systemic, and I would think beyond infection in this child. Okay,
Yes.
thank you. Please go ahead.
Past history. No history of similar illness in the past. No history of blood transfusions in the past. No history of prolonged fever in the past. No history of prolonged being injured site in the past. No history of hospitalization in the past. No history of recurrent infections in the past. Antenatal history. Mother's age was 26 years and father's age was 24 years. First child was male child, 6 years, healthy. Current child is male child, 4 years, 6 months. First nurse, spontaneous conception. Confirmed pregnancy by a urine pregnancy test performed in her home. At the time of conception, gestation age was 8 weeks. It was a booked pregnancy, taken folic acid and calcium. Dating scan was done, it was normal. No history of excessive vomiting, no history of fever with rash or UTI, no history of hospital admission. Weight gain was present gradually. No history of alcohol consumption or smoking. Second trimester, quickening was at 5th month, taken iron and folic acid tablets. Anomaly scan done, it was normal. 2 doses of tetanus received. No history of reduced perception of fetal movements. No history of discharge per vagina. No history of bleeding per vagina, or no history of leaking or draining per vagina. No history of alcohol consumption or smoking. No history of hospital admission. Adequate
No.
weight
If
gain was
everything is
present.
normal, don't see. What about see?
Yes, sir.
No point in writing everything. See, nothing. Was there anything significant in the antenatal period?
No, sir.
Then leave it. Don't write all this. No need.
Yes, sir.
Yeah. Uneventful antenatal period. Okay. Birth and neonatal.
Yes, sir. It was an
Anything
external
relevant?
delivery due DH concave.
Anything important
No, sir.
related to the
Did-
present disease?
No, sir. No.
Slide.
Skip
Next
it.
slide.
Save time. Go to the next slide. Development,
Sir,
anything relevant?
which is
Anything relevant?
no, sir. No, sir.
Okay. Dietary history, anything important?
Sir, at the time of illness, patient is taking less calories and protein, sir.
Which nutritional problem can result in a similar picture in this child? Tell me
B12
one
deficiency, sir. B12
disorder.
deficiency.
Pardon?
B12 deficiency, sir. B12 deficiency.
B12 deficiency. No, that will cause more of anemia or neurological manifestation. Can anybody put in the chat box which nutritional disorder can present like this? Scurvy.
Yeah.
Somebody has put correctly. Debbie.
Correct.
Scurvy. You know,
Yes.
if you look at the history of scurvy, it occurs in adults who are in prisons, who are starving. Okay. It occurs in infants and young children who are not given fruits or fruit juices, who are starving. Emotionally neglected children, malnourished children, they can suffer from bleeding like this. Okay, scurvy. Right? We
Praveen,
don't
how
see
many
that.
cases of B12 deficiency you have seen presenting with bleeding?
Yeah, but B12 deficiency can have pancytopenia, but
But
presenting
the
as
commonest presentation is anemia. Usually they present with anemia, but they
neurological. Go ahead. Okay, go ahead.
It's a pedigree chart.
Hmm.
Family history, sir. It also no significance. So family history also no history, sir. History
Anything
also is
relevant?
no list of food drugs.
Okay.
No, sir.
Family share. Okay, next slide.
Immunization history. Patient is fully immunized as per age according to universal immunization program.
Okay,
Last
next
vaccine was
slide.
given at 18 months of age. This is
Next slide.
yes.
Next slide.
Social.
Anything relevant? Okay. Now, what
No,
is
sir.
your summary? What is your summary?
4 years, 6 months old child, second born to non-consanguineous married couple, presented with chief complaints of fever, rash, and non-stoppage of bleeding following injury with no chronic illness in the past and no significant family history. I would like to consider possibility of infective or hematological etiology, sir.
Infective or hematology? What do you mean by hematological etiology?
The platelets functions.
Pardon?
Platelets, sir,
Will
disorder of blood, sir, blood disorders.
Blood disorder. Which blood disorder will cause fever?
Means, no, sir, like acute leukemias, anything, acute leukemias, ITP.
ITP. How many cases of ITP you have seen so far?
Sir, 7, 8 cases I have seen, sir.
Tell me what is the most important thing which is against ITP? ITP is the last diagnosis I'll make in this boy, in this child. Sorry, the girl.
Bleeding, sir, bleeding is there.
Bleeding can occur in no, that's not the thing. Fever, yeah. ITP is not a disease which bothers you with fever. ITP
Yes, sir.
is an immunological affair. It is a post-infective disorder. You get a history of fever 2 to 3 weeks before. ITP is like Guillain-Barré. You don't have fever in Guillain-Barré. You don't have fever in ITP. If fever is present, think beyond ITP. It's a post-infective immunological disorder. So this sort of 5 days fever
Yes, sir.
does not occur in ITP. So ITP is not there. Second is ITP doesn't cause bleeding after trauma, after trivial trauma like this. The bleeding will stop if there is a trivial bleeding if it is ITP. I don't think you should consider ITP at all in this child. As I said
Yes, sir.
earlier, this is a child with an acute febrile illness with probable thrombocytopenia and also a coagulation factor defect, a combination of both due to a lymphoreticular malignancy or an unusual infection. That will be my conclusion in this child. right?
Praveen, you
Go
said
ahead. Go.
vaccination. What else is important? You said whenever suppose a child is having chronic problem, something like this, what will you observe after vaccination? What is the thing you will be asking for,
Sir,
looking?
hematoma we will check, sir. This kind of hematoma we will check, sir. After IM vaccination, hematoma is there or not, we will check, sir.
Yeah, suppose you are having any doubt whether this problem is acute or maybe chronic problem, you could have always asked but whether the child has recently received any injections. Whatever
Yes, sir.
injection, it may be antibiotic or it may be vaccine and all, and whether there was any bleeding after that, right?
Yes, sir. Yes,
Yeah,
sir.
and one more important, as sir said, if the child is having bleeding after trivial trauma, so it should not go on for days like this, right? So that means if the child is
Yes, sir.
bleeding, it is not only a platelet problem, it may be something else to do with coagulation cascade. So that also thing we should remember. A child with low platelet
Yes,
or
sir.
functional platelet defect may bleed after trivial trauma, but usually they stop after some time, right?
Yes, sir.
Okay.
Can you think of a disorder where there is both the platelet problem and the coagulation problem? Hereditary. Particularly, this is a female child. I'm giving clue after clue. Can anybody put in the chat box? Female child has a problem with platelet function and also got a problem with coagulation. Von Willebrand's, yeah. Von Willebrand's is one of the diagnoses you have to consider. The only point against that is the presence of fever for 5 days. That's very much against. Okay, Von Willebrand's can present with both purpura due to platelet disorder and coagulation disorder simulating hemophilia. Okay, in a female child particularly.
Yes, sir.
Okay, go ahead. Could this be DIVC, disseminated intravascular coagulation?
It can be, sir, because patient buildings that can fever is also there, sir. Can
Only
be
thing
DSC
is,
also, sir.
child will be very, very ill. Very well, very ill. But you, from your history, there is nothing to suggest child has been too ill. Too ill, too ill.
Yes, sir.
If it is lymphoreticular malignancy, which lymphoreticular malignancy will you think of? What are the lymphoreticular malignancies will you think of in this child who has presented like this with an acute febrile illness with thrombocytopenia and coagulation disorder?
ALL, sir.
Pardon? ALL. Okay.
AML.
I'm saying this is not looking like ALL. Why? Okay. What are the differences in the clinical features of ALL versus non-ALL? As a clinician, when will you start thinking of leukemia which is not lymphocytic? I hope you get my question.
Yes, sir.
Yeah. Can anybody put in the chat box? Okay. To save time, I'll tell you. The important clues to the presence of a leukemia other than non-lymphocytic are one DIVC. DIVC is one of the manifestations of promyelocytic leukemia. Gingival hypertrophy, proptosis, chloroma. These are all features which tell you that the leukemia is not lymphocytic, non-lymphocytic. Okay. Similarly, if you have a child who has got superior mediastinal obstruction with edema of the neck, respiratory distress, X-ray showing superior mediastinal adenopathy, you'll have to think of T-cell leukemia. If you have a testicular swelling in leukemia, you'll have to think of a lymphocytic leukemia. So these are all some of the clues. So in this child who has got a coagulation defect and probably a thrombocytopenia, I will think beyond lymphocytic leukemia and I will think of a non-lymphocytic leukemia. Okay. go ahead, give your presentation of findings to Naresh.
Yes. General appearance, child looks active and playful. Nutrition status, weight for height, -1 SB2 median. Height for age, median to +1 standard deviation. Weight for height, -2 standard deviation to -1 standard deviation. Head circumference is -1 standard deviation to median. Madam circumference is 14, it's normal. These are classification of IAP guidelines, sir. IAP charts. Vital signs, temperature was 98.6 degree Fahrenheit. Tachycardia night axilla. Heart rate was 120 per minute. Respiratory rate was 23 per minute. Abdomen was type. Blood pressure was 98 by 48 mm mercury. Systolic BP was 58 percentile. And diastolic BP was 58 percentile. Recorded right sitting posture and right down. Pulse was palpable. Rate was 120 per minute. Rhythm regular. Volume normal. Character no special character. No radiofemoral delay or no radial delay. Peripheries were warm. SpO2 was 99% at room air. RBS was 108 milligram per deciliter. CRT was less than 3 seconds. General examination, mild failure was present. Picture, cyanosis, clubbing, edema, lymphadenopathy were absent. Physical examination, child is conscious and oriented. This is surface 15 by 15. Stature, posture, face is normal. Facial dysmorphism absent. Specific finding, ecchymosis is present over the right nasolabial fold region. Neck normal, thorax normal, abdomen. Purpura and ecchymosis is present over the abdomen. Any orifice is normal, gently normal. This is the photo, sir. You can see the left, this is the left front region, bleeding was there. There's a locus hematoma was there. Second photo, you can see the right nasolabial region, ecchymosis was there. And left elbow region, there was, after IV blood sampling, there was ecchymosis was there. But after blood sampling, the blood marking was there. This abdomen photo, you can see the purpura and ecchymosis over the abdomen region.
See, the findings are very good, but once you go to the first slide on examination,
Yes, sir.
first slide. What is the heart rate? Is at 120?
120 per minute, sir.
Is it normal for this child? Temperature is
No, sir,
normal.
like the tachycardia is there. Tachycardia is there, sir. Yes, sir.
Why the child is in tachycardia? One
The
more slide.
failure
One
was there,
slide.
sir. Mild.
So you said mild pallor, na?
Yes, sir.
First of all, you should say pallor is there or not. There is nothing called quantification, mild, moderate, severe, and all. Okay.
Yes, sir.
So, is it the first slide
Yes, sir.
on examination? Yeah. Go back, go back. See, whenever you see a child, whatever case you are having, no, first you should mention, now you have mentioned your general appearance, the child looks active and playful. But whatever is clinching at your first glance, you should mention. I always tell my students, for example, a
Yes, sir.
child is in distress or the child is having multiple ecchymotic patches here. So you should mention in that. You should not wait. What is very no clinching to your eyes? No, for example, child is severely malnourished, okay, or the child is very ectric, or the child is having pale, very pale. So you should be telling that at first glance that this child is having this. You need not wait for head to toe examination at all. Okay. But this child is active and playful, right?
Yes, sir.
Okay. So any child who is active and playful and this child is having these findings on general appearance. So what are your things? What will you think of in your mind? What are the possibilities? with the background history of.
So everything finding it, suppose baby is active and finding it can be an ITP, finding will be there. So in ITP, the same baby will be perfectly normal, sir. Only the papillary grasses will be there. It can be ITP, may finding milk, sir.
ITP, suppose I consider your history and I'll examine this child, I'll not think of ITP, right? As sir already
No,
mentioned,
yes,
so
sir.
the child is usually the child with ITP doesn't present with fever. Okay. But suppose I don't
Yes,
tell
sir.
you the history, and if I show you this child, suppose I don't know the history, I see this child first time. So what will be my first impression? A
HSP
well-looking
or
child.
ITP, sir.
HSP. Why HSP? Where is the rash
Sir, well, look,
here? What is the local? What is the
abdomen.
location of the rash? Is it palpable or non-palpable? Sir has already told, no? If the child is having purpura which are palpable, you think of vasculitis, right?
Yes, sir.
And distribution of
But
rash.
it's
Where
not
do you get?
palpable.
What is the distribution of rash in HSP? It's mainly over the lower limbs, buttocks, right?
Yes, sir.
Usually
Yes, sir.
dependent parts. So lower limbs and buttocks, they are most prominent sites for HSP. So this child is active and playful. And if the child is having ecchymosis or purpuric rash and all, the first impression, of course, on appearance, I will think of ITP, right? Such is the impression. But if I take that history, background history in my mind, I will not think of ITP. I look for something else also. Okay. Is there any lymphadenopathy on your
Yes, sir.
examination?
No lymphadenopathy, sir. No, sir.
No lymphadenopathy. You want to look for
No,
lymphadenopathy.
sir.
Suppose the child is having few lymph nodes in the cervical area. So is it
Yes, sir.
normal or abnormal? When will you say it is normal, considering this background?
Cervical lymph node less than 1 centimeter is normal, sir. Palpable, non-tender, non-fixed mobile.
What is
If it
significant
is more than 1 centimeter fixed, then cervical lymph node size more than 1 centimeter, sir. Not mobile, tender, fixed. It is significant lymphadenopathy, sir. Inguinal
What
lymph node
size?
size more than 2
Cervical
centimeter.
lymph node, what size is
Fixed, non
significant?
2, sir. 2 centimeter.
2 centimeters.
Sir, more than 1 centimeter, sir. 1.
Inguinal?
2, inguinal 2.
See, cervical, it is 2 centimeter. Some books say 1.5 centimeter, but it is 2 centimeter. Inguinal lymphadenopathy more than 1.5. How about epitrochlear lymph nodes?
Not palpable, sir. Check towards this, no, it's not palpable, sir.
But
If it also
they
not
are
palpable.
present and they are more than 0.5 centimeter, they are considered significant, right?
Yes,
Apart
sir.
from size, what else is significant? When do you say significant lymphadenopathy?
Sir, tender, sir, or fixed, not mobile, or matting of lymph nodes, sir.
Suppose a child is having non-tender lymphadenopathy. Do you think this is more problematic? A child is having tender lymphadenopathy, that is more problematic.
Sir,
Suppose this child is having 2
tender
centimeter
is
lymph nodes, but they are firm, they are not tender, they are something like rubbery and all. So what do you think it is? It is problematic or
it can be Hodgkin lymphoma, sir, problematic, sir. Tender lymph nodes are infective pathology, can be dental caries, tonsillitis. It can be very less severe, sir. But painless lymph nodes are more severe, can be less lymphomas.
in other words, if the child is not having tenderness, for example, it is not painful, do not reassure the child. Okay. And if it is consistency is rubbery or if there is matting and even size also, based on these parameters, you can say it is significant or not significant lymphadenopathy. Okay. Chalo, next.
1
Yes,
minute,
sir.
1 minute, doctor.
sir.
There are 2 or 3 important points one must remember when it comes to lymphadenopathy. The most important fundamental point one must remember is that the size of the lymph node matters only for regional lymphadenopathy. For generalized lymphadenopathy, the size does not matter. If you have even 0.5 centimeter all over, cervical, axillary, inguinal, etc., That is significant. That is significant. On the other hand, for a regional adenopathy, the size matters. For example, cervical, you have, easy. I mean, I remember it very in a simple manner. Epitrochlear 0.5, axillary 1 centimeter, cervical 1.5, inguinal 2 centimeter. The rule of thumb. And one lymph node, if palpable, is always pathological. Can you tell me which lymph node is that? It's not epitrochlear. Epitrochlear also can be palpable in normal individual. One lymph node, if it is palpable, any individual, is always pathological. Which lymph node? Supraclavicular,
Yes.
left supraclavicular. Left supraclavicular is always pathological. So these are all important points you must remember. Go ahead. Go ahead.
Examination of abdomen, inspection. Child is
What happened? Hello.
Hello, Praveen.
Naresh, are you hearing him?
Yeah, no, sir, no. I think he'll come back. Got disconnected, I guess. Ah, he's coming
Slide
back.
is also not visible.
hello, sir. Audio, sir.
Yeah.
Hello.
You can,
Oh,
you
sir.
can, yeah, continue.
Yes, sir. Examination of abdomen. Inspection. Child is lying in supine position with hips flexed. Shape normal. Flanks not full. Umbilicus normal in size, shape, and position. No discharges. Movements. All 9 quadrants of abdomen moves equally with expiration. Visible pulsations absent. In multiple purpura ecchymosis present all over abdomen. Veins not seen. Perithalsis absent. Swelling absent. Perineal orifice normal. Palpation. Child is lying in supine position with hips flexed. Local temperature normal. Feel of abdomen soft. Tenderness absent. Godly rigidity absent. Divercation of recti absent. Deep palpation liver. 5 centimeter palpable below the right septal margin in right mid-clavicular line. Edges were rounded. Surface was smooth. Consistency firm. Absent. Moving with patient present. Spleen not palpable.
Slide is not visible.
Okay.
Spleen. Your slide is not coming up. Spleen palpable or
Spleen
not
not palpable, sir. Not palpable. Not palpable, sir.
Now it is visible.
Is there hepatomegaly?
Epidemiology is there, sir.
Why
Sir. Less
why
span
you
was
say
40 centimeters,
hepatomegaly?
sir.
Okay.
The normal lifespan for 6 months is 9.5 centimeters, 9 to 10 centimeters, sir. 40 centimeters. It's enlarged actually, sir. Fluid will absent, sipping dullness absent, vowel sounds present and heard 15 per minute. Bruit absent. Examination of action genitalia. Type was male genitalia. Scrotum was normal. Rugae present. Penis normal. Cordate. Action intermediate normal position. Testis, parietal testis, palpable both sides scrotum. Anal canal opening present. So I can skip the system, sir. It's normal, sir.
Your slides are gone again. Slide. Have you completed? What is the summary after examination? Once.
4-year, 6-month-old child, second born to non-consanguineous marriage, presented with chief complaints of fever, rash, and non-stoppage of bleeding following injury with no chronic illness in the past. and shows significant family history, I would like to consider the possibility of infective hematological etiology with inflammatory and migraine pathology. I would like to know the possibility of acute leukemia, sir, or I will change the diagnosis as acute leukemias or lymphocytic system involvement, sir.
I don't think you should consider dengue at all in this child.
Yes, sir. I
A
show you
child
at
who
the early
doesn't
stage,
have
sir.
any.
Not even ITP.
No. ITP
Not
and
e-
dengue.
not
Absolutely.
Yes, sir.
See, basically, you must remember next to you cannot say acute leukemia, lymphoreticular malignancy, because the same picture can occur in
both.
leukemia as well as in grade 4 lymphoma, stage 4 lymphoma. Sometimes in histiocytosis also. Langerhans cell histiocytosis can exactly present like this, with pancytopenia, with hepatomegaly, with rash, etc.
Non-Burkitt lymphoma, non-Hodgkin
Okay.
lymphoma.
Then the next
sir.
diagnosis, see, other than lymphoreticular malignancy, in this child, the next would be an immunological diagnosis. For example, the possibility of hemophagocytosis
Yes,
is very much there in this child. HLH is very much there in this child. And the other possibility is, of course, the duration is very short. It's an immunological disorder, autoimmune disorder, like, for example, SOJA. Because you don't get thrombocytopenia, you don't get bleeding, that makes it very unlikely. 3-year-old child, you're not going to think of lupus that common, but monogenic lupus can occur in this case, in this age. And of course, third will be an unusual infection. Unusual, for example, parvovirus infection, CMV infection, EBV infection, HIV can present exactly the same way, with fever, bleeding diathesis, and hepatomegaly. These are all the possibilities you have to keep in mind. Right? I don't think I will consider dengue at all. ITP is not there in the diagnosis of this child. You don't get hepatomegaly in ITP. It straight away is ruled out.
Yes, sir.
Okay? Go ahead.
Even Praveen, even if you are thinking of dengue, suppose this presentation may be a complication of dengue in some situation, HLH. Okay, it may be secondary to enteric also, or it may be secondary to some inflammatory conditions also, HLS, as Sir said. But again, that is also here, it is unlikely because the presentation is not typical of dengue here. Suppose you have a child who is having features of dengue. Now the child is in a critical phase and child has not recovered. Child has in fact worsened, like increasing hepatosplenomegaly or bleeding and all. Then you can think of HLH something. So there is maybe background, some history or some underlying disease may be there. That is secondary HLH we are talking about. Okay.
Could this be a chronic liver disease with hepatocellular failure with coagulopathy causing bleeding?
Sir,
You said liver is
previously-
palpable 5 centimeters.
the previous child was apparently pretty normal, sir. No finding was there, no melena was there.
Nothing to
no
suggest any
previous
chronic liver disease.
child
Clumping
was-
is not there, jaundice is not there, edema is not there, right? No very
And growth is
bleeding.
also normal,
Yes, sir.
sir. Growth is also
absolutely
appropriate.
normal. Yeah, that makes it unlikely. Okay, what will you do? What will you do for this child?
Sir, I will
How will you
take
investigate this
routine
child?
Yes, sir. I will take routine CBC count, sir. Then I will.
What did the CBC show?
Yes, sir, I'm showing. Hemoglobin was 9.8 gram per deciliter. WBC count was 4,200. Platelet count was 10,000. Neutrophil was 21.1%. Lymphocyte was 63%. Hematocrit was 29.3%. MCB was 63.7. MCH was 20.9 picogram. MCHC was 40.6 gram per deciliter. RDW was 16.1%.
Does this look like dengue? Does this look like dengue?
No, sir. Hematocrit was corresponding, sir. 9.8 into 3.
Okay. Go ahead.
CBC PSF. RBCs were normocytic, normochromic with presence of macrocytes and anisocytosis. WBCs, total count is reduced.
What about mean platelet volume? 1 minute. What about mean platelet volume? Is
Sir,
that
actually,
important?
it's, yes,
Not
sir.
mentioned.
Not mentioned.
Not mentioned. Is it important?
Uh,
In which disease it will be useful? ITP, yeah. ITP, you can get a clue from mean platelet volume,
yes, sir.
isn't it?
Yes,
And
sir.
in the smear, somebody has put it. Giant platelets may be there, which may give a clue to dengue. Go to the next slide.
Peripheral smear, RBCs, normosteric, normochromic with presence of macrophages and endocytosis. WBCs, total count is reduced and activated lymphocytes are seen. Platelets severely reduced, hemoparasites not seen. Same creatinine was 0.6 milligram per deciliter. SGOT was 73 units per liter, and SGPT was 18 units per liter. SPLC was performed, was normal steady state. Then dengue NS antigen was negative. Dengue IgM antibody was negative. Myocarditis was negative. ICDCT was negative. P nutrition was normal. USG abdomen so only hepatomegaly of 1 centimeter.
If you are thinking of
Bone marrow activation was
1 minute, 1 minute. If you are thinking of lymphoreticular malignancies, tell me 2 blood investigations you should have ordered, other than what you did. Can anybody put in the
sir.
chat box? Lymphoreticular malignancies, 2 other investigations. LDH and uric acid would have given a clue.
Yes, sir.
Both might go up if it is a lymphoreticular malignancy. Right? And one other investigation I would have definitely considered if the child is febrile is also serum ferritin. Why? Anything above 1000, you will start thinking of a HLH or a macrophage activation syndrome. Right? Go ahead.
Bone marrow aspiration was performed. It shows erythropoiesis suppressed with homoblastic maturation pattern and occasional megaloblast. Megakaryopoiesis.
1 minute,
blast
1
cells,
minute, 1 minute. Before bone marrow, did you do PT, PTT?
that actually, done actually, sir, but report normal actually, sir.
So
PT,
in this child who has had such severe bleed, I would have definitely done a PT, PTT before doing a bone marrow.
Yes, sir.
Is it normal? Was it normal?
Normal, sir. PT, APTT, PTANR, sir, all normal, sir. LFT, all normal, sir. So only did bone marrow also, sir.
Okay, go ahead. Go ahead.
Erythropoiesis suppressed with normoblastic maturation pattern and occasional megaloblast seen. Megakaryopoiesis, blast cell 70% noted, round 2 oval in shape, hyperchromatic nuclei, 2 to 3 nucleoli, coarse chromatin, scanty cytoplasm, 2 showing granules. Impression, future suggestive acute leukemia.
Acute lymphocytic or non-lymphocytic?
Sir, they didn't mention, sir. They advise a flow cytometry actually, sir. They didn't mention actually. Sir.
Have you done chest X-ray? Chest X-ray.
Yes, sir. I didn't approach her, but it's normal, sir. Finding no highlight.
Why you want to do chest X-ray?
Sir, every time, mid-cell mass will be there, sir. Mid-cell mass, report mid-cell mass, report mid-cell widening, sir.
Which condition you get mass mediation? Which type of leukemia you get?
Lymphoma, sir.
Or T-cell leukemias.
Yes, sir.
They may present T-cell leukemias.
Yes, sir.
Tell me one thing out of interest. I'm asking you one question. Suppose a child is having platelet of 20,000, okay, and one child is ITP, the other child is having leukemia or some bone marrow disease. Which one is likely to bleed?
Acute leukemia, sir. Leukemia disease.
Why? Why?
Sir,
Both
ITP
are having
only
similar platelet count, right?
Yes, sir.
And your PT-PTT is normal. As for example, PT-PTT is normal. Then which child will bleed?
Sir, leukemia child will acute, chronic ITP patient will not bleed, sir. ITP 30% will be only bleed, sir. Will not develop bleed. Only leukemia
Right.
patient will develop
He
bleed.
may bleed. He may bleed. Right, not bleed. But which are more likely to bleed?
Leukemia patient, sir.
Why? What is the exact cause? See, any child who is having acute ITP, whatever the platelets they are released in the circulation, they are very young and active, and they are hemostatically active.
Yes,
So that's why many of the patients you see ITP, even 5,000, 10,000, they don't bleed. Right? Because they are functionally good platelets. Whereas a child is in chronic disease, for example, leukemia or otherwise, so the child, the platelets, whatever they are released, they are not young. They are very hemostatically, they are less active. That's the reason the bleeding does take place in those with bone marrow disease early than in ITP, right?
yes, sir.
Yeah, the other important thing you must remember, in this child, I would never have given any sedation for bone marrow without doing a chest X-ray. Because, it is dangerous to sedate a child or give anesthesia to a child who has mediastinal adenopathy. An X-ray chest is mandatory before giving anesthesia or intubation or sedation for any child like this. You should have done an X-ray. Make it a point. Yeah. Go ahead.
Done, sir. Yes.
Yeah, what else will you do for this child in terms of investigation? You should do HIV. And nowadays, all leukemias, you always do the immunohistochemistry to type the leukemia for prognosis and management.
Yes.
Right? HIV is important. Flow cytometry or your immunohistochemistry should be done for this child before starting any chemotherapy, right? Naresh,
Yeah,
final
I think-
remarks?
Yeah, that was a really nice case and nice presentation, Dr. Praveen. And we all today's case presentation. And thank you, Bala sir. It was a dream come true to share the stage with you, been my teacher, and got high regards for you. And really, I'll remember this presentation and sharing the stage with you. Thank you so much, sir.
Kishore sir, your comments, and any senior faculty attending, you can give your comments before we wind up.
Okay.
Students, if you have any question, you can post it in the chat box. We'll try to answer if possible.
There is no question till now, sir.
Okay. Your comments, Kishore, before
So-
we wind up.
So it was a nice case.
Yeah, Dr. Praveen, you presented very, very well. Okay. Of course, you are full of knowledge and your speed is very high. So you have to match the speed of the slow speed of people like me. So you did extremely well. Hats off to you. Well done. Keep it up. You're full of knowledge and wisdom. All the best to you.
Dr. Praveen, can you stop your slide sharing?
Yes, sir.
Stop sharing.
Yes, sir.
Sir, there is no any question in the chat box, sir.
Okay.
First of all, I like to congratulate and thanks Dr. Praveen for his nice presentation and very beautiful discussion. Thank you, Dr. Bala sir and Dr. Motwani sir, for sparing your valuable time with us and enlightening us with your great knowledge and thought process, sir. Thank you, sir. Thank you all the viewers, Dr. Anas Thakur sir, Smita Kothari madam, Nutan sir, Ganesh Misra, and all the attendees for attending this webinar. Last but not the least, thank you, Mr. Joshi ji and whole Juventus team for their technical support. Thank you all. Good night. Thank you.
Thanks,
Thank you, sir.
DBAP. Thank you, DBAP. And thank you again, Bala sir. Good night, sir. Thank you.
Thank you, sir. Good night all.